Look at this.
All
This is a
right. Well, yeah, nice. 16 people. Wow, that's nice. So welcome everybody to International Renal Rounds that we actually kind of rebranded to the Extracorporeal Hour to reflect a little bit more the extent of all the topics we're discussing during these rounds that are way past renal replacement for a long time and include therapeutic apheresis, hemoperfusion, and any other kind of extracorporeal therapies, and why not in the future? I don't know, maybe extracorporeal membrane oxygenation or CO2 removal. If somebody wants to get to it and discuss that, that would be interesting. So happy New Year! Very happy to see that we have a large assembly today. Um, and yeah, I don't know, Jethro, what do you want to add?
Yeah, no, I think Cedric summed it up really nicely. We are looking to move forward this year, starting 2026 with this first session in a way that I think when Cedric and I sat down to kind of chat about this, we really wanted to drive the interactive component to this and really wanted to develop this culture of these meetings as open and comfortable. And to kind of set that off, I think it might help for the two of us to kind of share a little bit about of our journey and then open the floor to you guys. And in that vein of interaction and sharing cases and learning from each other, Cedric's working on a sign up sheet so that folks can offer cases ahead of time to chat about and get a little bit of a head start on the next meeting. Um, but just from my own experience, I've been involved in the extracorporeal world for since about 2010 or so, and a number of different functions and with different mentors along the way, and including many of the names that are on here and continue to be mentors for me. And I will say this as much as I bring some experience to these chats. Man, I am humbled. Every case I've got humbles me, and I learned so much from hearing about some of the challenges that you guys have had, and again, Cedric has had, and it's taken me kind of being able to put myself out there and say, this is what I tried, and I know you guys know more than I do, but this is what I did. What do you guys think? What's some feedback? It might have been a better way to do it. There might be maybe I've done something different that you guys can learn from as well. But I think that's the tone for these meetings that we're really hoping to drive. And with that, really taking some of the I guess the anonymity out of things as well. And so with that, before I hand it back over to Cedric to introduce himself a bit more too, I'd love to invite you guys to turn your cameras on too, so that we can actually see you guys as well as you see us. Make sure nobody's sleeping out there. But just before I wrap up, in case any of you guys don't know me, I'm an assistant clinical professor at Cornell University. I founded and direct our extracorporeal therapies unit. And yeah, I'm hoping to learn from you guys, and hopefully you guys will learn something from these discussions too. So I'll turn it back over to Cedric.
Yeah, and so I'm Cedric Dufayet. I'm the director of the Extractable Service for UC Davis in the satellite location in San Diego. I've been lucky to be the trainee of Doctors Cargill and Dr. Ross here in San Diego, and I've stayed here ever since. So I'm probably like 8 to 10 years into my journey in extractable therapies now. So yes, I would love, I mean, if some of you want to say anything, can like briefly introduce yourself, show your face to the community there, don't be shy. And then we'll call up to see if anybody wants to bring a discussion topic or if anybody has a case to present for today, and we'll get it going. Anybody wants to jump in?
Jenny looks like she's about to say something. I love that. She looks cold, but she looks like she's ready to chat. How are you?
Yeah. I've come in a bit left field into here, but delighted to see this group. So I am from my accent, you might be able to guess I'm from the UK. So I'm coming in a little bit left field in the fact that we have a lot of legislation over here that stops us doing quite a few things. There is very small amounts of extracorporeal therapies going on within the academic institutes in the UK, but I'm probably one of very few people in the UK that is doing apheresis, but a little bit different because I do it for platelet collection. So I'm using a hemonetic system to collect platelets to use for regen medicine therapies because of the fact that's the only way we can use them at the moment. So lots of experience doing apheresis, but not so much the clinical side. So I'm here to learn from all you guys because I want to branch out a little bit more and help a lot more over this side of the pond, looking at how we can pull together, because I totally agree with you. This stuff is funky as, absolutely brilliant, totally reliant on the person doing it. Different every single time, and I'm dealing with fit well cases with decent circulation that are usually about I do a lot of horses and some dogs all over 25 kilo. I'm dealing with a lot different to you, so I'm here to learn basically. But that's my background. Anybody wants to know how to take platelets off anything, I'm your girl. Other than that, I'm a little bit I'm floundering. I'm learning from you lots.
Oh, that's awesome, Jenny. Thanks for being here, and looking forward to everything you have to add to the conversation, and hopefully we can share some good experiences that you can pick up on too.
Well, you're gonna have to make a little brief presentation of what you're doing for platelet collection and how to use them afterwards. That would be an awesome topic, I think, for one of the next rounds. I'm a bit excited to hear about it. Anybody else wants to?
Mandy's unmuting there. Are you in California these days, Mandy?
I'm in California. Yeah, I'm Mandy Spillane. I'm in Orange County right now. So I was in Los Angeles, but I'm in the process of starting a extracorporeal unit and nephrology service in Orange County. So yeah, just kind of in a transition, but I love extracorporeal stuff. There's always a new complication, I feel like. So always learning and just want to kind of join the conversation.
Are you in Dustin now?
Yes.
You'll have to get April on here one of these days.
Yeah, April actually is keen to learn, so I'm gonna train her, and then hopefully there'll be two of us, which is gonna be better than one person kind of trying to do extracorporeal therapy. I feel like is challenging. So yeah, I kind of planted the seed that maybe she wants to do the ACVNU residency too. So we'll see.
Nice. And Mandy, I think, maybe we'll keep going with some introductions, but as you're just getting that unit off the ground, I think one of the really cool topics here, and maybe I'm biased because I've gone through it a couple of times, establishing a unit, kind of where to start from an equipment standpoint, from a staffing standpoint, your on-call availability, and building that team up of people power as well as equipment. And, you start with everything, you start with one platform. I think that'd be a great conversation for one of these sessions too.
Yeah, definitely. I think that's a great discussion to have because I think there's lots of ways to do it. And I did set it up once in LA. So I learned a lot from that experience and we'll see how we go this time around. So yeah, definitely keen to have that discussion.
Wonderful.
So Mandy, now that you're in Orange County, I see that you are promoting and advertising the 70th anniversary of Disneyland.
Yeah, I love kidneys and I love Disney are my two things. So when I'm not kind of having kidneys, I'll be at Disney. So I think that's the thing with the on-call schedule to figure out, do you leave Disney to go in? Yeah, that will be the challenge. So
Well,
anyone wants to come to Disney, you let me know.
70th year anniversary.
Mm-hmm.
Well, Dr. Calgo,
I'm coming, Mandy.
No.
Yeah, Carolyn, you should come. We have a spare room now that we're adults, so you can totally come and stay and check it out.
I was going to invite Dr. Calgo. Probably doesn't need an introduction here, but for anybody on the call that might not know who you are, I wondered if Cedric had mentioned that he trained with you, of course. I've learned a ton from you, as have probably everybody on here involved in the extracorporeal world. But would you mind just telling us, in case anybody doesn't know who you are?
Well, thanks for throwing me under the bus here, Jethro. So I'm Larry Calgillief. I used to very happily run these rounds, but am so thrilled now that it's turned over to two really capable people. I started doing extracorporeal therapies in about 1971, And as Mandy sort of articulated, it became a passion, and it becomes a passion every day. It's just these therapies are evolving. They're not static, and you can just learn and grow with them forever. So thrilled with the new logo and the new thoughts and energy that you two are bringing to what used to be the renal replacement rounds. Good transition.
Cedric, I heard like he almost said we were great for a second there, and then he changed it to capable. But I love it.
Which in Calgary standard is already very nice, you know.
Yeah. Well, again, we're building, and I think the phrase is standing on the shoulders of giants that came before us, of which obviously Dr. Calgill is one of. So we're definitely thrilled to still have you a part of these discussions and bringing all your wealth of experience and knowledge and sage wisdom to the conversations as well. Carolyn had unmuted there for a second as well, talking about Disney. I wondered if you might jump in and tell us about yourself too.
Hi, I'm Carolyn. I work at Tufts Veterinary Medical Center in Massachusetts. I'm actually a technician. I'm not a doctor, but I work as the extracorporeal technician at Tufts. I've been working for the service for exclusively for about 8 years, but I worked in our ECC for about 8 years prior to that and was helping with extracorporeal therapies. So I find it really fascinating. I love doing it, and it's really really great.
Amazing. So one of the reasons that we're putting people on the spot and asking people to speak up kind of off the bat here is Summer on behalf of the ACVNU sent out a survey recently asking for feedback on ways that these sessions could be even better than they already have been. And one of those pieces of feedback that we took to heart was the trying to reduce I guess the unmute video on stigma, the intimidation factor of some of these sessions, and really trying to remove that barrier to folks getting their voices heard and their faces seen and their cases discussed. So I don't know. This is such a great size group here. I don't know that we can invite everybody, at each session to do this, but hopefully I think we'll get a handful of new voices, new faces each time. And that way we'll all start to build this community and get as comfortable with each other as possible, so that we can really build on our collective expertise and grow this field that has been growing since 1971, as Dr. Calgill said, and just continues to thrive. And it's just exploding with people doing this. And in the same vein, learning from each other, but raising the bar, raising the level of care that we're providing for these animal patients that we're doing these services and performing these therapies for, to make it better for all of us. So. Alice, I see you jumped on there with your camera, so I'm hoping that meant that you might want to introduce yourself and break the silence.
Yeah, sure. Hi, everyone. I'm Alice Defarge. I had trouble with my camera at the beginning, so I fixed it. I'm one internist. I'm a professor in small animal internal medicine at the Ontario Vet College in Canada. In Ontario, I've been passionated by urology and nephrology for many years. I got board certification in 2008, and since then I've been growing the service in minimally invasive urology at the Ontario Vet College, and I took the academy course in 2018, 2019. So since then, my passion has grown a lot for extracorporeal therapy. I've been working with the ICU to do more and more extracorporeal therapy. So we got like a Prismaflex in 2018, and then we got the Spectra through grant application for research in 2022. Thanks to Cedric, who I visited. Like I practiced with Cedric on fake like patient and then one cat overnight. So it was really good, but it has been challenging for me to be honest, to get more practice. Like at the Ontario Vet College, we see like quite a few patients. Like we're seeing like 1 or 2 patients every 2 months. It has grown, but then it's not enough to get more comfortable with the procedure. And then sometimes I'm on clinic, sometimes I'm busy with something else. So it has been like difficult. So I'm taking a research leave in September, and hopefully I will be able to visit Carrie Palm, maybe Cedric. And I'm looking for, I'm networking with the human hospital around me to visit them like once a week and make sure that I can be exposed. So I think my experience in extracorporeal therapy needs a lot of practice, and I feel I'm not like ready to be the lead on that. So I need, like, I'm very lucky. We have a great ICU team, and they took the academy course as well, and then they're really like getting masters in that, I think. So it will be helpful. But anyway, sorry, it's a long introduction, but I'm very passionate. I've been intimidated by these rounds. I understand the feedback that the others said, because I don't feel like sometimes I feel like I'm not experienced enough to ask questions because I don't have the background or um, all the knowledge that I should to ask those questions. I'm far behind all of you, but I'm very passionate, and I want to get better at it. So thank you for the opportunity to introduce myself.
Alice, it's so great to hear your voice and listen to your introduction there. And I want to say this, and Cedric, you jump in as well. But where you're coming from and what you just shared, as far as your feeling of not knowing enough to ask questions or to contribute here, you're the type of person, and you're in the position that we really want to build this up for, because that is how we get all of us doing a better job and feeling more confident and comfortable, and helping more patients, and then helping more of our colleagues grow and do better. So you set the tone perfectly for what this group can be. And we'll have some higher level conversations as well. In the background, in between these every other week sessions, we're all like texting and calling and sharing cases and talking about stuff as well. And so while these sessions are dedicated to this, building that network of communication and sharing in between that is also going to be really, really powerful. And the only way we do that is by unmuting and saying hi and putting ourselves out there a little bit too, so that then you've got more resources. The other thing that I think, in between these sessions as well, from my point, and Cedric and I haven't talked too much about this, but I think I can probably speak for him too. We'd love to start sharing some of our sessions in real time as well. Many of us on this call, I know Carolyn at Tufts, we've got cameras in our units as well. So I think Erica and a few others, Erica Reinecke's over at UPenn, running a program. We had a session maybe 2 months ago. I was running an IHD session on a small patient, and we had alarms going off left, right, and center throughout the entire hour. And it was really humbling. I'll use that word again. Embarrassing a little bit too, but everybody got to see some of the struggles, and people were chiming in with, oh, you know what, when I have that alarm, I tried this, or this pressure goes up, and you know what, here's how I overcame that and troubleshot it before. Dr. Ueda Yu is on here from NC State as well. So, all of that collective experience can help us get better, and it's okay to admit that I don't know a lot of stuff. I probably know less than I wish I did for sure, but we're going to grow that. So anyway, those video sessions in between of our live stream of some of our treatments, I think might be another way to branch off of these every other week sessions. So I don't know, Cedric, do you want to chime in on any of that?
No, I totally agree. I mean, the goal is really to build a community, to learn to know each other, and to share as much knowledge and experience as we can. So, I mean, now that we're like 20 minutes into the rounds, I mean, maybe we can keep some of our introduction for in 2 weeks from now and see if anybody wants to bring up a topic or bring up a case. And if not, I mean, Jethro and I may have something in
No.
that
Can I
we
jump
can
in?
present today. Sorry?
Can I start? Can I start, like start introducing myself and for you guys then to know? Um,
Sure.
I'm I'm Chai
I see
and
you.
I'm from South and I'm as assistant professor in Chiang Mai University. I've been in the academy since like 2020 to 21 class. And then at the begin, we have starting the dialysis unit in like 4 years ago. We just got a new machine, and I didn't know like when what to start, so I joined the academy, and then right now we trying to doing the small patient with like bypass system, and and also trying to build up the one gizmo from the like looking at the Dr. Kalkio patent that what he described and all this one, and trying to do that one too, and I'm like very a little bit feel better when I heard Jethro talking about the alarming when running with the the small patient that very difficult for me to run and stay focused when alarming go on and on and on, and we are trying to like doing better, learn from the group and then learn from the your experience. And we also trying to build up the team. We have only four of us, like two vets, one nurse, and one like assistant. The other one, like hopefully we can have a bigger team in the future. Like
Yeah, that's nice to hear. Thank you for the introduction. And I mean, I think that's one thing that everybody struggles with is like building a big enough team to have coverage and not get exhausted running those treatments. It's something that is sometimes underestimated, I think, is the really the human resources that you put around the dialysis unit. As far as when the alarm goes, like the first thing I've learned from my mentors is just like push the mute button. First thing. Because you cannot think if it's blaring in your ears, right? So mute it, and then you can actually think better. That's the fellowship 101. Like first thing to learn is like how to tie the dog on the table and mute the alarm when it goes off. All
Awesome.
right.
Well,
So
yeah, I was just gonna say, we look forward to hearing how you build your unit and how your experiences go, and maybe we can help troubleshoot some of those alarms down the road as well.
uh, for me,
yeah.
can you say again? The connection is not good, Jethro.
Oh, sorry. Yeah, I was just saying we look forward to hearing more about how your unit's growing and how your caseload expands and other challenges that you meet and how you overcome them.
Okay, hope so. Thank you.
Yeah. So yeah, I
Right.
think Cedric invited. I know we're just kicking off the new year here. I don't know if anybody's got a recent case that they'd like to share with the group. If you have something prepared visually, wonderful. If you want to just kind of chat through it, that's great too. And that's the other I think from the expectation. Certainly Cedric and I like our PowerPoint slides. And so we put stuff together and prepare those for you guys. And I know Dr. Cowgill has done that historically as well. But that doesn't have to be that's not a standard necessarily. That's just to help illustrate because we like talking about this stuff and putting it down on slides. But we have a number of folks that, just kind of off the cuff present, here's a case, here's what I went through, and we can chat through without some of the visual stuff as well. So, with that, is there anybody out there that's got a case that is brave enough to present that presented a unique challenge, something you learned from, or something you want to gather some input from us on?
So we had a unique case last week. I don't know. This may not interest everybody, but last week, and I'm not turning my camera on because 2 days ago I was sick as a dog. So I'm still not feeling great. But last week we treated a 2-day-old calf, Jersey cow, with hemoperfusion for sepsis. And I have very limited experience with cows, but per se, but we were told that the calf's recovery was fairly remarkable after treatment. So my understanding is the calf was born premature, at least 12 days prematurely, and failed to thrive. Was born on Monday. By Tuesday, was in our large animal hospital and being treated for septicemia. Received one plasma transfusion and then was failing to nurse at all. They gave it colostrum via a tube. And then we discussed kind of doing hemoperfusion. And so Tuesday, the calf was there. Wednesday morning, we proceeded to kind of get everything together, and we treated the calf for 6 hours on one of the Cytoclear columns from Amylogic. We decided to treat for 6 hours versus treating for blood volumes, just because we weren't really sure, and we were basing some of this on some of the work that Dr. Hobbs has done. Now she's down in Texas A&M. She had said that they've considered and done treatment on horses for like 7 to 8 hours. So we treated the calf for 6 hours. We did collect samples, which we're just trying to figure out where we can send them for cytokine evaluation. But by the end of the session, the cow, at the start of the session, she was brick red. Like where I shaved her for placement of dialysis catheter, she was really super injected. Her sclera were very red. Her conjunctiva were super red. By the end of the session, she was still mildly injected. She was splotchy, I would call it, in patches, but was much improved. She took a small bottle. She nursed a little bit. By the next morning, she was nursing strongly. And she went home day before yesterday with no further transfusions and no further need for tube feedings.
Well, so you said you were sick as a dog. Maybe you were sick as a calf. Sorry, folks. That's going to be the kind of silliness you might get from me every now and then. Carolyn, you mentioned the that is really cool. That's we're looking at a similar type of casework here at Cornell as well, and we've got some partners in the large animal farm animal world on my side here too. But I wondered, so you mentioned the brick red, the injected mucous membrane, some of that in the conjunctival injection started to resolve through treatment. Can you speak on some of the other, surge parameters, so heart rate and, blood pressure if you had it? I don't know if you take blood pressure in a calf or not. Are there other indications that there was improvement through the treatment?
That was a hard one for us too. I'm like, I don't know about large animal. I was like, I was like, I would like to monitor this creature do you have a multi-parameter monitor? They're like, we don't do those things here. So that was a little hard for me. So I brought my multi-parameter monitor over and I was like, this cow's small enough. I put a blood pressure cuff on her tail. Her blood pressure did improve during the session. Her heart rate was never really bad. She was hypothermic, consistently hypothermic, prior to the session. She came in febrile, but then became hypothermic and remained hypothermic. I put a fluid warmer on the line, so I can't really say that, whether or not she was improving due to the fluid warmer or whether or not that was due to the treatment itself, but her temperature was normal by the time we ended the session. So her blood pressure did improve. Starting at the session, her mean was hanging around the 60s. By the end, her mean was in the 80s to 90s of the session. She seemed a little bit brighter, maybe a little bit more mentally appropriate by the end of the session. By the next day, she was able to stand by the end of the session with a lot of assistance. By the next day, she was standing on her own. So
I'm curious, how did you manage the vascular access? Like, what kind of catheter did you use? How did you choose like the length of the catheter? Do you think you were to the atrium or more like in the jugular vein? Was there any challenge specific to like being a calf compared to a dog?
Oh, yes. There was one huge challenge, and that was her skin. I totally didn't think about the fact that, cowhide, her skin was incredibly thick. Incredibly thick. She was really quite small. She was only about 14 kilos. So we do all of our dog catheter placements under fluoroscopic guidance. And our radiology team was fine with us bringing her over to fluoroscopy as long as we put a table drape down. So we draped the table and we did it under fluoroscopic guidance. She was really quite ill, and so we only gave her a very small dose of midazolam and were able to put the catheter in. Her skin was incredibly thick, and normally I just nick over the guide wire and make that kind of incision. But in this case, I actually had the dilator was so kind of stiff going in that I actually made a larger hole. Once the dilator was in, I kind of nicked over the dilator, and that allowed our dialysis catheter to pass. It was we using a 13.5 French MedComp catheter that was 30 centimeters. It was right in her right atrium, and so we were able to flow at whatever we wanted. We limited our flow, I think, on her to 200 mils a minute, and we were at 200 mils a minute basically for the entire 6 hours.
And why the 200 mils a minute? Was it like for the cartridge, or were you looking at your delta pressure on the cartridge and you were like having high delta pressure at higher flows, or was it just like a random choice?
No pressure problems whatsoever. The delta pressure on the column was below 20 the entire session. We chose 200 just because talking to you, Jeff Barnes at Amologic and so on, and his biochemist Jose, they've said that an ideal flow and dwell time within the column is usually at about 200 to 250 mils a minute. So we opted to run at 200 mils a minute for 6 hours. We exchanged 86 blood volumes on the calf with that blood speed in that time.
And what platform did you use to run the
We
treatment?
used the Revive pump. The Amologic Revive pump is what we have.
I might offer some comments about vascular placement. Some of these alternate species we've done a few horses over the years, and if you're looking at an animal like a horse or a llama, you have the addition to the very, very tough skin, and that's a reality. Horses seem to have very, very reactive vessels, and sometimes you fuss with those vessels a little bit and they just vasoconstrict. So you want to get your catheter or your wire in quickly. And the other issue in those species is that they tend to have valves, very potent valves along the length of the vessel. And sometimes you have to break through those valves in order to get appropriate directional flow. So those would be considerations that you should think about also. But good job on that calf. I saw the before and after pictures. That was great.
And I think also I would concur like about the flow in the V300 cartridge. And it's been my experience in bigger dogs where I tried to run more than 250 a minute, and it seemed like the the circuit was not tolerating that very well, and the sweet spot was between 200 and 250. It really seems to be like a nice flow to have on that type of cartridge, at least.
And I would compliment the long treatment time. That was a good job, because I think that's what you likely need.
Does anyone else have comments on the treatment time? I know they're not on here, but our New Orleans team at MedVet, and I think I saw Parker on here too, used the CytoSorb, and they were able to, with good ICU nursing care, run the hemoperfusion for 24 hours because they were worried about, kind of constantly having that clearance. And the couple of cases they did that on, really impressive results as well in terms of being able to wean off like triple pressors and a lot of things like that. But our sort of impression from their experience was that we really needed to try to push for those longer times, and that 24-hour time they felt was superior to when they did shorter times. This were dogs. Has anyone else seen that benefit from those extended times? Is this one of those where really time, given the constant production of cytokines and the level of sepsis, is what we're shooting for, like Carolyn said, versus blood volumes?
I mean, I don't have experience with 24-hour treatments with hemoperfusion for sepsis, but it always kind of made sense to me that shorter treatment times, you would probably like decrease the amount of cytokines in the bloodstream very well, but you would also have like cytokine levels back to baseline within a few hours after that. It just makes more sense to me to think about it like as a continuous treatment if logistically you can do that, and I guess that's how they do it in people. Like these people receive CRT with a hemoperfusion device associated with it, and so they're on the machine like continuously at least 22 hours a day with some break time for like CT scans or whatsoever. But they're not doing intermittent hemoperfusion for sepsis. It's more continuous. And it's probably the direction we need to head for. We don't have enough data. I guess like there's like some teams working on gathering that data as we speak. But yeah, I wouldn't be surprised if we show that longer treatment times are the way to go.
For 24-hour treatments, what are your thoughts on like dosing of medications that the patient needs? I assume a lot of these are going to be removed by some of these devices, and if they're getting important therapies concurrently, like how do you balance the drugs or the medications they need with the extracorporeal removal of those?
Well, I think there's pretty extensive literature on the human side looking at these problems, and a lot of time the way they deal with that is just by adding CRIs, whether it's for antibiotics or over medication. The depressors usually are on a CRI already, and they might actually bump the dose or bump the rate just to compensate for the extracorporeal removal. I feel like it really gets very complicated. Like every time I'm trying to look into that, because most of the data is there's some experimental data, there's some like in vivo data in patients, but it feels that it's still very empirical. Like they kind of like, okay, well, we know we've got some removal, so we're going to bump the dose by X%. And that's kind of the way they do it. But you really need to dig into the literature to look at specific drug removal and how they handle that. But there are some guidelines, but it really needs a lot of digging. And I don't think on the veterinary side, anybody has done that kind of data collection and or has extensive experience for those. I don't know if anybody has more experience on that or was like,
I just want to add something.
Yeah.
I know we have the AKI management guidelines and there we have the recommendations for how to calculate the recommended dosage according to the AKI grade. I actually don't do those calculations. I often only use the same dose, and I know it's very empirical and anecdotal, but we don't see any problem using the same doses. Only if we are going to use a nephrotoxic dose, we try to stay between guidelines or research what they are doing in the human side for that drug.
Yeah, and I think Cedric alluded to it, and Nav as well, and Parker might jump on and say something about this as well. But it comes down to the drug removal with the device that you're using as well. So in some devices and some modalities we've got good data on what drugs are removed, and their physical chemical properties are going to dictate some of that. So in a lot of these cases where, I'm sure the Tufts team, kind of got thrown in the mix there without being able to do hours upon hours of, background research on what they were removing or not removing. So some of it will come after the fact. Therapeutic drug monitoring would be another really nice way to start getting some of this out there so we can share that information as well. But knowing which drugs are removed and then making some empirical decisions, I think is how I would go about it, or CRIs like Cedric suggested to try but even then, we don't know if we're, a CRI, there's some question with CRI in the antimicrobial world. If you turn it off for 5 minutes because you've got a pump alarm or something else, do you drop below the therapeutic range on that? Should we be bolusing intermittently, or the CRIs? There's a lot to learn from that. And so we're going to have to use a little bit of clinical judgment, dig into the literature before and after the fact sometimes, and then bring it to these discussions, bring what you learn to these discussions so that we can benefit from each other's experience that way.
Also, sorry, I remember that in the first academy I attended, we had an assignment from JD to make this type of information to know what type of drugs can be removed and what percentage. And I remember we were going to do a handbook or something. I don't know if he has something similar already, but that will be really great if we could all do and make some to give information to everybody in that booklet, right?
I agree. I mean, I remember that project on the first academy, and I think at the time it was more also to look at what we could treat for like toxicities and overdose and things like that. But it also goes into like drug monitoring during hemoperfusion or CRT treatments. I think it's a project that we collectively want to see happen, and then I mean, sometimes there's a work group going on, and we don't follow through enough. But I agree that would be a very nice thing to bring together, and especially if some people have some real life data in veterinary medicine. Just to rebound of what Andres was saying about intermittent hemodialysis, I see that a little bit different, because I feel like with intermittent hemodialysis, you're doing a 4 or 5 hour treatment. And even if the drug that you're using for the patient are removed, it's very easy to just redose after the treatment and don't fuss too much about it. I feel it's way more challenging as soon as you step into CRT world, because now you've got a continuous treatment. So there's no question about, whatever I remove, I can redose after the treatment, because the treatment is continuous. And that's why it gets very much more challenging, I feel like, to understand what you're doing. But I think, Parker, you started to speak. Maybe you get some more information about Cytosorb or Vet Rescue on that matter.
Yeah, thank you, Cedric, and thank you, Jethro. I will say what you guys are experiencing now is echoed from our over a decade of experience on the human side. You guys are facing the same challenges, length of treatment, as well as dealing with unintended removal of certain therapeutic agents. And there's a number of ways that we've addressed this on the human side, and then some folks using Vet Rescue for sepsis are addressing this as well, as Jane mentioned down in New Orleans. And this can be done simply by taking a pause in therapy, allowing for the other medications to circulate and do their job for a couple hours, and then restarting therapy. So that's how it's often done on the human side. As Jane mentioned and alluded to, and you talked about, Cedric, that issue with rebound is a real issue. And so when we do SLED or intermittent hemodialysis in these treatments, what we see on the human side is that you do have that rebound but you guys may not have the staff, obviously, for these longer therapeutic treatments. So sometimes it's on that initial day when you say they are a candidate, maybe you give them 2 treatments that first day and then follow up and evaluate them the following day to see if they need a subsequent treatment. Because if we go too long, all that good work that you guys are doing with your therapies, unfortunately, the body, until it's actually recovered and had time to heal, and the other therapies are working, you're not going to see the desired outcomes more often than not.
And I think that speaks to, I mean, when we're talking about inflammatory diseases, sepsis, non-septic SIRS, I mean, we're talking about a balance of pro and anti-inflammatory cytokines as well here. And some of these, devices may be less selective and might be taking out some of these messengers and cytokines that might be beneficial. So there's that consideration as well. When I philosophically kind of think about what we're doing with a lot of our extracorporeal therapies, whether it's renal replacements or even some of the therapeutic plasma exchange or cytokine removal, I feel like we're lifting a weight off of these patients to allow some of the other treatments that we're providing for them to allow their inherent ability to recover, to just have a little bit of a breather while we remove some of those heavy negative cytokines and other substances that were taken out. And it may be to Parker's point that we give them a little bit of a break and we watch for some of the clinical improvements that Caroline was describing. Get some hard data after the fact, because we don't have too many bedside ways to measure some of these cytokine levels, and then develop, is it an 8-hour treatment and a pause because our staffing, isn't available to treat 24/7 or 24 hours at a time even. Is it one treatment, then two? Is it a third? Do we use clinical parameters? This is where it's so exciting to share all this information, and we're going to have to build some of these, consensus, if you will, but recommendations out of our own experiences, borrowing from Parker's team and what they've got on the human side as well, to try to adapt to what's practical for us too, because it's not always practical for us to run these 24 hours at a time.
The other consideration for why we treated for 6 hours was because the night before, and we treated on New Year's Eve, but the night before we came in at 1 a.m. to treat an ibuprofen toxicity as well. So we treated from 1 a.m. We finished that dog just about 7, and then we went straight into treating the cow. So that was part of our consideration, that we were all already really, really exhausted. So staffing played a really, really big part in that decision on treatment time.
Great point.
And I fully agree. I mean, it sometimes it's part of the prescription decision. I mean, it's something that I'm testing all the time. Like if I'm starting a treatment in the middle of the night, and depending on what I'm doing the next day, I might make some different choices than if it's in the middle of the afternoon. Just because, you've got staffing issues, you've got yourself, like you might have not slept the day before. I mean, even if those things shouldn't come into play that much, they do in real life. I mean, and we shouldn't be shy about talking about it. And just like sometimes, like I got a call last weekend for a transfer of a very unstable patient that was on a vent. It was just like, well, no, I don't have the staffing to receive that patient today. I mean, tomorrow might be better because I will have full staff, but we're not going to be able to handle that patient on the Sunday as he should be managed. And sometimes you have to be able to judge the situation and maybe delay a treatment or shorten a treatment and come back like the next day, maybe with a longer treatment because you just couldn't do the ideal treatment on the spot. And I think there's no shame in admitting it. And sometimes it's better care than having an exhausted staff that doesn't pay attention to the patient. So, I mean, those are definitely things that we should take in consideration.
Well, I think that falls into that category of putting your own oxygen mask on first before putting it on the person who's sitting next to you. Mandy might be at Disneyland, or Carolyn. I'm not going to talk to Carolyn about boundaries and how much she puts into patient care in these treatments, because she's dedicated and relentless in how much she gives to her patients up there at Tufts. But I do, Alice, you've been so patient with your hand up there for seemingly 20 minutes or so. What did you have to add here?
Oh, that's okay. It was not related completely with the with this particular topic of the duration of the treatment. So I was happy to wait and listen to the great discussion. I just had something in mind because we got the spectral TIA, and then now the next step would be to get the cartridges for hemoperfusion and the machine. Um, and I got super excited at the last renal week when I heard about this new hemoperfusion for sepsis. I remember there was a great talk about it, and the ICU team was also very excited. How available it is, and and I can go online and like offline, I mean, and email um, like the company to have like more information if it's more relevant. But I would love to hear like what was the cost for this calf, for example, to use like a cartridge, and are we talking about the same kind of budget as for the spectral TI use, like for like a TPE, or like is it like a little bit less expensive? Like I know it's always hard to give like a number, but I just want to know the range of the budget the client is looking at, and if it's available or if it's partly research related for now.
Well, I wonder if maybe Parker and Jeff is on there as well. Maybe you guys could put your contact in the chat there to have a little bit more of
Yeah.
that conversation too. However, I can speak to some of this. I've got a couple slides. Hopefully I'll have a minute to show you guys too on a foal that we treated who is septic. So I mean your catheter placement charges, everything that goes with an extracorporeal treatment in terms of catheter, tech time, your time. That type of budgeting, very similar in these cases, and then depending on your treatment duration, that's a consideration there. In terms of we're talking about hemoperfusion devices here in particular, and there's two that we're all mostly familiar with. One being the vet rescue device, and then the amylogic devices as well. Those have individual costs associated with the cartridges themselves. Then the platform that you use to run the treatments on may have some variability in terms of I know from my end here, when we purchased our machines and when we set this up, we have cost recoup for each treatment built into some of those prices to clients. However, with all of that said, and these devices can be integrated into your Prismaflex, for example, as well as the amazing work that both of these groups have done to have standalone hemoperfusion devices for these columns. The other element to all of this as well is finding that balance. It'd be another great discussion for a whole session of charging what I would, in air quotes, say appropriately for our time and our expertise and our disposables and our technicians and all the rest of the resources that go into treating these patients, balanced with a conversation with our administration or the folks that set our price points we need to grow these therapies, and we need to make them accessible for folks as well. We all need to compensate the people that need to be compensated and pay the bills and keep the lights on and the rest. But in terms of, and Carolyn can speak on the CAF, myself and some of my team here, and I think Dr. Del Vescovo has just jumped on with us as well. When we have some of these novel type of cases, we do try and find ways that we can use catheters that might be nearing or just past their expiration date, for example, in a septic foal we had. Both of these hemoperfusion companies have been very generous in saying, listen, this is a unique application. Let's talk about finding a middle ground here so that we can make it accessible and affordable for these patients, these clients that might not have the budget that we might otherwise expect from some of the other cat and dog applications. So there's some wonderful ways that we try and find a sweet spot there, accounting for all the budgetary things that we have to charge for, but also we're all here to help, and to learn and to grow and to find new ways that we can make a difference. And so there's a middle ground there somewhere, and it's going to be a little bit different based on, I don't know what the admin and the hospital directors at OVC, taskmasters that keep you on budget, and charge for things. And then some folks like, on our end have a little bit of a research budget that will apply to some of these cases as well to try and make it achievable, so we can learn and then publish and grow the knowledge base.
Thank you, Jethro. It's really helpful. I think our admin is pretty powerful and strict, as you probably heard, but we usually go through research dollars or donation, actually. So we have a powerful population of horse owners, and sometimes they wanna chime in and they wanna get the best for their foals, and so it's interesting. Thank you for posting your contact in the chat. I will certainly get in touch with you. Thanks, Jeff and Parker.
And Dr. Cowgill's patiently raised his hand.
No, I'm not patiently, but I wanted to just reiterate along the lines of your discussion, Jethro. I've always advocated whenever I'm asked to comment on somebody setting up an extracorporeal unit, one of the things that I've had the good fortune to have, and I think every extracorporeal program ought to try to develop, is an indigent fund. Which maybe is created by development or a grateful client or maybe administratively, but you're going to see patients that absolutely could benefit from your therapy, but there's just aren't the resources to manage it, and so that's one use of funds, that you just have this pot of money that could support. Partially support. I think most of these clients need to have some investment in the therapy, but to have a source of funds that you can use to treat the patient that's got a very good prognosis for recovery if it can just get the treatment. The other thing that these funds, you need a fund also to investigate your mistakes. So if you're having a problem, and geez, I really needed to get blood cultures on that patient, or I needed to do this, or I needed to send this off, and there isn't a budget to do that, you never learn from those mistakes. So to have some amount of dedicated funds that you can use to troubleshoot problems, or to troubleshoot issues, or to gather data that really shouldn't be on the back of the client, but that's useful for your own extracorporeal development. Every program ought to have that kind of a resource, in my opinion.
Thank you very much, Dr. Cowgill.
And I think Haley also wanted to add something.
I wanted to ask what you think about the filter, Baxter's filter, OxyIris. I know that here in Israel, human doctors use it for sepsis, and that's their go when it comes. It's also like hemoperfusion, and also it's a hemofiltration. It's like both worlds. And what do you think about that? Because we already have the machine, PrismaFlex, and it's just buy a different filter. If you have any experience with this filter, or because there's more, I think, research on the human side with that filter, especially it came out especially for COVID-19. So if anybody tried it.
I personally haven't, but like you said, it integrates right into your Prismax or Prismaflexes, which is appealing. I don't know, Cedric, have you had any experience or know anybody?
No, I've not tried it. I've definitely heard about it and read about it. Well, the first thing, it's a pretty big filter, so it's probably more appropriate for larger patient than smaller patient, even if you could argue that a smaller circuit with a hemoperfusion cartridge might still be pretty big. It's supposed to remove cytokines, but it's probably not as efficient as straight up hemoperfusion in these cases. But it's definitely a good choice in some ICU patients that need renal replacement and are also in some kind of of sepsis. And there's a lot of literature coming up on that. I haven't dug into that literature too much because, again, it's more of a continuous treatment modality that I can't really put in place in my current setting, but it's definitely worth looking into. And actually, that could be a very nice topic to talk about for a future round, I think. And we could do like a little bit of a lead search on that and try to come up with something. And I think it could like trigger good discussions and maybe some research ideas in that field as well. I don't know if anybody else has had any experience with the Oxiris. Right. Well, I think definitely that would be a nice topic for later. It sounds like we are like almost at the end of the hour. I just wanted quickly to share my screen. So if you can see my screen, you've got my email address, Jethro email address. If you want to submit some topics, if you want to ask questions in between session, you're welcome to reach out. The QR code should get you to the sign-up sheet. So if you want to go through the hassle of preparing a nice presentation about, I don't know, platelet collection in the UK, you probably can just like, sign up for a date, and we'll make sure that you will have ample time to do your presentation and show your work to the rest of the community. And also like we can advertise about it, and if nobody signs up for a session, that's also a good sign for myself or for Jethro to have something up our sleeve to discuss during the session, even if we didn't have to do anything today. And I cannot be more happy about it. Like 30 people on the rounds, I think that's awesome. Very good discussion. Nice to see some faces on camera. I don't know many people actually took a turn to speak, but probably about a dozen people. So that's really what we want to see for the next rounds, and I cannot be happy for that first round of 2026.
Yeah, amazing. This was such a powerful start to the year, and you guys made that possible. This is great. Thank you everybody for the input, the sharing, the questions, and being brave enough to get on here. And we're going to continue this in 2 weeks, and we'll go from there.
All right. Well, thanks everyone. See you in 2 weeks, and please sign up, please reach out, and even if it's just like to slip an idea of discussion to one of us too. Have a good rest of your day, or have a good night for those in Europe, because I know it's a tough time.
Thanks, everyone.
Thank you.